At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Well, thank you very much, and good afternoon, everyone, or good morning, depending on what part of the country you're from, and happy Digital Health Week to you. As many of you probably know, Canada Health Infoway, along with a number of sponsoring organizations, are celebrating Digital Health Week, and we're happy to have this webinar as part of that series, or as part of that event. And this is our third webinar from the Data Impact Challenge. And as our conference host said, we are looking at question 2, which is the rate of repeated diagnostic imaging tests. You all probably know the dial-in number because you're in already, so that's a good thing. Marianne from ISIS, if you're dialed in, could you please hang up as we're trying to reach you? For those of you that are tweeters, we encourage you to tweet using the Infoway handle there and then the hashtag Data Challenge. Just to like to inform everyone that this session is being recorded, although most of you won't be asking questions directly using your voice. You'll be using the Q&A feature, but these will be used and posted on our website for educational purposes and sharing. As our host said, the Q&A feature is how you will ask questions, and you can see here up in the upper right-hand corner of your screen is where the Q&A icon is, and then you type information down into the panelists, direct your question to the panelists, and as we go through the webinar, we'll make sure we address your questions. If you're thinking of some now, we encourage you to put them in now because we'd like to have as many questions as we can to answer. So a brief sort of look at what we're going to do in the next hour. I'm going to give you some background. My colleague Simon is actually going to present to you some findings. We're going to have presentations from a couple of teams that actually submitted during the challenge to this question. And then we have a guest who's going to facilitate some discussions for us. And so then this is where you can ask and join our dialogue on some of the answers to these questions. So many of you have been part of our webinars already and have heard my song and dance about Canada Health Infoway. But for those of you new joining us, Canada Health Infoway, our vision is healthier Canadians through the use of innovative digital health technologies. With our partners, we help accelerate the development, adoption, and effective use of digital health solutions across the country. The Imagination Challenges specifically seek to inspire, provoke, and promote innovation in health and healthcare and foster a community of innovators throughout the country. And again, for all of you that participated in our Data Impact Challenge, and for those of you that are joining our webinar to hear some of the results of that challenge, we consider you part of our community. With each Imagination Challenge, they're slightly different. They all share the same ultimate goal to improve the quality of care and patient experience. We couldn't run these challenges without the support of our supporting organizations. You can see them all listed there on the screen. With this challenge, we had some invaluable help from the Canadian Institute for Health Information, Choosing Wisely Canada, and the Canadian Association for Health Services and Research. So I'd like to thank all of our supporting organizations, and we continue to seek your assistance on helping to spread the word about these challenges. So the purpose of the Data Impact Challenge was to source relevant information to a set of questions or topics on quality or appropriateness of care. We, worked with our supporting organizations to come up with all of these questions, and I think, as you can see by the results, we were overwhelmed by the type of response that we got to information that hasn't really been known in a broad sense in the Canadian marketplace. So it tested the feasibility of this new mechanism, matching stakeholders who sort of have the information and to the policymakers who want the information. You can look at all of the challenge submissions on our website, and it's there for you to look at. So I'm going to turn it over to Simon. Simon's a colleague here at Canada Health Infoway in our benefits realization section, and Simon's going to talk about some of the results.
Great. Thanks so much, Fraser. So at a very high level, as Fraser mentioned, we put out these questions, 6 questions in all, and one of those questions was a multiple-part question that we worked on with our partners at Choosing Wisely Canada. So lots of challenging issues for folks to tackle. We gave the team 64 days, and in that time we were thrilled to get a total of 41 submissions. We really felt it was a very strong, really good quality of submissions as well, which was very important. And the other really important component of this was our judges. So we had 35 judges, a really strong group of judges, and they were able to provide a really rich sense of feedback about the quality of those submissions. As Fraser has mentioned, all of this information is available up on the Imagination website, so we really encourage you to go and have a look at all those submissions, have a look at those judges to understand the folks who are looking at this, give you a really good sense of what we've learned over this process. But without further ado, I'm going to dive into our question at hand today, which is what is the rate of repeated diagnostic imaging tests within a 90-day period? So for this particular question, we received 6 submissions. We received a series, 4 of them from Ontario and 2 of them from Alberta. All of those submissions, again, available on the website. And on the website, you can also see a little bit more detail about the question that we asked. So we provided with that question the rationale and some specifications, and all that is there to be reviewed. Now, this question was of particular interest to us at Canada Health Infoway because duplicate diagnostic imaging is one of the important components of the value proposition for electronic health record investments, and specifically diagnostic imaging systems and diagnostic imaging repositories. And so we're very pleased to have on the line with us today a group of people from our Diagnostic Imaging Jurisdictional Implementers Group. So these are folks that work in the provinces and territories and are implementing and operating the solutions that consolidate diagnostic images. And we'll be calling on them a little bit later in the call to have some discussion around the opportunities and progress thus far. But first we're going to see some of the results from the findings. I'm going to start by just providing a brief review of a few of the findings that inspired this question. So in the literature over the last number of years, we've seen some great evidence that relates to rates of duplication and also the value that digital health can bring to reining in some of those duplicates. So we've got a study that was done here in Canada, really in the relatively early days of DI in terms of the connectivity across settings, and this was looking specifically at an area in London, Ontario, and looking at how much that duplication rate changed over the course of the implementation of a shared PACS system. So we had a 9.8% duplication rate within 60 days of X-rays, and that dropped by an absolute rate of 0.9%. We also have a couple of studies from the U.S. which are more recent and are really focusing on looking at health information exchange, which is the U.S. equivalent in many ways of our electronic health record, and really looks at sharing information between providers. And in that context, they looked at what are the duplication rates for different modalities and what are the impacts of having health information exchange. And again, we see relatively high duplication rates, some variation across those studies, but certainly not insignificant duplication rates. And we also see the impact of having that health information exchange coming into play and being a factor for reducing those. So that's a big driver for us, is understanding what is the actual rate of duplication and how can digital health drive forward and help to ensure that utilization of diagnostic imaging is appropriate. So the next couple of slides I'm going to show you are a really high-level summary of those 6 submissions. submissions all, as I said, looked at different data sources. We're looking at different provinces, different time frames, and also dove into some different modalities. In this first slide, what we've done is summarize the findings that relate to the higher cost and lower volume kinds of imaging, MRI, CT, and ultrasound. And what we see here is some variation, certainly, but a range emerging there, and the bulk of the evidence falling into some pretty narrow corridors. On the next slide, we've then summarized the imaging that is either of across all images or specific to X-ray. And in this data, some of it is cut by setting, which is another interesting angle that we might be able to dive into a little bit here. So again, a fair amount of variation in what we see is the duplication rates, but there's nothing that's close to zero. So there's definitely a substantial amount of duplication that we're seeing, and some of them are fairly high duplication rates. So definitely evidence that we want to dive into, as this is a significant aspect of health system funding. So that's the summary, but now we're going to dive into some of the details. And so I'm going to now invite our first team to join us and speak to their results. So this first team is the Western Pirates. And I'm pleased to invite Eric MacArthur, who is an analyst at ICIS, at the ICIS Western facility in London, to share their findings. Eric, I'll turn it over to you now.
All right, perfect. Can you hear me?
Yes, we can.
Okay, so as you said, we're the Western Pirates team. We're a team here in London, Ontario, based out of the ICIS Western facility. So you can see there were 6 of us involved in this team, myself, Eric MacArthur, as well as Ahmed Al-Jaishi and Quan Liu, who are epidemiologists and analysts, respectively. And then we had 3 physicians involved as well, with 2 nephrologists and 1 urologist. So if we move on to the next slide, you can see here at ICIS, we have access to a wide range of data sources. So we leverage these databases to pull a huge number of images within the calendar year of 2013. So we used OHIP fee codes billed by radiologists to identify specific common cross-sectional imaging tests. So specifically, we looked at CT or MRI of the head, chest, abdomen, or pelvis, or an ultrasound of the abdomen or pelvis. So choosing these specifically were guided based on the physician input on our team. They thought these ones would be most common. They would be most costly to the system, likely, and some of them as well are, you're dealing with radiation exposure as well, so there's potential that inappropriate repeats of these would also be harmful to the patient. So we defined a repeat as evidence of an OHIP billing for the same imaging site and the same imaging modality within 90 days of the initial record. So they had to have a CT of the head, and to be a repeat, it would have to be a CT of the head as well. It couldn't be an MRI of the head or a CT of the chest or something. It had to be the exact same modality and location. So you'll see that within 2013, we found over 7 million imaging records, and this involved more than 2 million unique patients. And overall, our proportion of repeat within 90 days was 13%. And you can see there's quite a wide range of variation across the different modalities and locations. So CT chest was the highest at 19%. And then it was as low as 2% for MRI chest, with all of the MRIs being quite uncommonly repeated. And then as an additional analysis, we looked at a subset of the population who reside here in southwestern Ontario. Here in London and in the surrounding hospitals, I believe it's 12 hospitals in the surrounding area have a linked radiology viewing system available. So across all of these hospitals, the physicians are able to see the images that occurred at other sites potentially. So we thought that having this linked system would potentially decrease the amount of repeats, since it would allow physicians to see images that were done at other centers. And as you'll see, it was a 13% relative reduction compared to the rest of Ontario. So we're seeing that 13% in the rest of Ontario repeated, whereas within this Cerner network, we're calling it, it was only 11%. So it may seem small, only 2%, but when you start multiplying that over millions of records and years of time, it adds up to be quite a lot of money as well. And that's it.
That's great. Thank you so much, Eric. Really appreciate that. I forgot to mention before Eric started that we are absolutely open to accept questions for Eric and his team now. So please go ahead and submit questions you have for him. We've got one or two here already that we'll move forward with, but we're open to more. So we have a question about the sites that are included from an Ontario perspective. And so obviously the other team will be presenting, will also be speaking to some Ontario data. But I wonder, Eric, if you can talk about the scope of data that was included in your analysis, geographically and also in terms of which settings those images represent.
Right, so this should be capturing essentially all of the province. There might be a few different locations that aren't doing fee-for-service billing, and there may be shadow billing, but it should be encapsulating the vast majority of the province. So this would be inpatient and outpatient for all of Ontario.
Great, thank you. So we have a question here about wait times. And it's basically, how do wait times differ by imaging modality? And do you think the lower repeats for MRI were influenced by longer wait times?
Yeah, that's interesting. I'd have to defer to the physicians on our team. I can't really say offhand what the wait times would be. They might have a better idea. But unfortunately, they weren't able to make it today. But that would be something worth looking into, I think.
No problem. That's a great question, and I should say we always throw the hard questions at you. So apologies, but we'll certainly happy to hear a follow up on that at some point. We were also interested in the idea of clinically appropriate duplicates. So obviously that's an important question to get at, is how many of these are really relevant duplicates. Had you put any thought into what kind of algorithms might be appropriate to try and isolate those which are in fact necessary and those from those which are not?
Yeah, it's something we discussed as a team. I think our approach here was just to look at all repeats, and it was obviously the most easy way to look at it. And within that 13%, there's definitely going to be some that are clinically indicated. But in terms of pulling out which may be inappropriate and appropriate is quite difficult to do with just our admin data.
Hi, this is Ahmed. I was a member on the team as well. So if I can just add to that very briefly. So we did also talk about in our last meeting that we could possibly, for example, exclude cancer patients who might have, who might be more likely to have these repeat DIs clinically indicated. So that could be a group that could be excluded from our analysis, or with cancer diagnosis. We have access to that data. But as you might know, the reason for the imaging procedure is not discussed in it's not available in the administrative records. So there's really no way to look at if it's appropriate or not. All we can do is assume that they're just repeated. Unless we go back to the charts, which would be not feasible for 7 million records.
Great, thanks. That's very helpful, and I think a topic that lots of folks are interested in. So interesting to have that discussion. And then maybe one last question for you, and it's about the type of information shared in that area that you were describing, sharing between hospitals. And maybe if you're able to elaborate a little bit about what functionality or what about that sharing do you feel has enabled some of that reduction in duplication?
So this is Ahmed again. I think what is shared is actually the entire, the image itself is shared, as well as the radiologist report. So that enables, if, for example, one physician does a imaging study and then another physician wants to see it, they can look at the same image that was done, so they don't have to repeat. But I think the image and the report are both shared.
Excellent. Thanks so much. Well, really appreciate that presentation and your willingness to field some questions. And please do stay on the line if you're able to, as we'll hope to engage you a little bit more as the discussion continues. But now we're going to move along to our second presentation from one of the submitting teams today. And this team is the Avengers. And I would like to welcome Miriam Vermeulen. Miriam, are you on the line?
Yes, I am.
Good to have you on the line, thanks. So, and I understand you're a staff scientist with ISIS.
Yes.
Great. So welcome, Miriam. I'll turn it over to you, and you can take the presentation away.
Okay, thank you very much for the opportunity. I was joined by a team of other staff at ISIS. Jag, who's a senior research analyst, Simon, who's unfortunately gone on to do his PhD, but was an epidemiologist here, Ryan, who's an epidemiologist, Diva, also an epidemiologist, and I, who at the time was an epidemiologist and have now moved into a new position, but we sort of did this rather independently of the clinician scientists here, which was a lot of fun, and we really enjoyed it. So, yeah, on to the next slide. Of course, we all know the question, and we really wanted to try to look at as many different modalities as possible to answer the question. So we looked at quite a variety and really looked at all body systems as well. We used the OHIP data, the physician claim data, and we looked over a little bit of a longer period. We also thought it might be interesting to look at trends over time. And the other restriction that we had was looking just at Ontario residents and adults. So we defined our tests as modality and body system specific, very similar to what ISIS Western did. You know, there's a lot of data considerations in this analysis. We had to sort through some of the challenges of the OHIP schedule of benefits in terms of professional and technical fees for the various modalities because they can be billed in quite different ways. And we also really wanted to make sure that we were grouping tests appropriately and not double counting where it wasn't appropriate. So that part was lots of fun as well. So just moving on to the findings. What we looked at it a couple of different ways in terms of repeats. As far as the number of tests that were repeated, we found a repeat rate of 17%. We also thought it might be interesting to look at individuals, and there we see that, you know, a lot of these repeats are done among the same individuals. So that rate was 35%. And again, looking at modality, there was quite a bit of variability where things like nuclear medicine and MRI had relatively low repeat rates. Echo and CT were a bit higher, and then the highest being ultrasound and X-ray, not surprisingly. We also, you probably noticed that our ultrasound, repeat rate for ultrasound is higher than what we were seeing from ISIS Western, and so we decided to take a closer look at that and acknowledging that ultrasounds for pregnancy and fertility reasons would probably be, you know, considered to be appropriate. We took those out and then examined the repeat rate and found that it was 10% when we did that. We looked at a few other things that aren't presented here. We were kind of interested in the types of people who are more likely to get a repeat test. We did find that women were more likely, for example, to undergo a repeat than men. We also examined the time to the repeat test and found there was quite a bit of variability where it was fairly long for things, or relatively longer, I guess, for things like CT, and shorter for things like X-ray and nuclear medicine. So I think that summarizes our results. Thank you very much.
Great. Thanks so much, Miriam. Really appreciate that. And again, we are now welcoming questions for Miriam about the work done by her team. So please use the WebEx tool to enter those in. We had a question about X-rays. So you mentioned sort of unsurprisingly X-rays were high. Do you want to elaborate a bit on that and why X-rays you weren't surprised to see them up in that 20% range?
Why we thought that was not surprising, that it was higher?
Yes.
Well, I mean, I think some of it is about availability. You know, it is more readily available, and it's a bit more, let's say, of a first line, you know, where people wouldn't necessarily, you know, go right to CT or MRI. They would first go, you know, to something like ultrasound or X-ray. So I think we were expecting those modalities to be a little higher than some of the tests that weren't as, you know, accessible.
Great, thank you. Really appreciated the bit of the discussion you added towards the end about your efforts to look at ultrasound and dive in to those rates and remove some of the folks for whom that might be clinically relevant. I wonder if I could ask if you have any further comments to the discussion we just had with the Pirates team about how you might, going forward, be able to identify some of those which are relevant and segment them from those which really are opportunities for improved utilization.
Yeah, I mean, we were quite interested in that discussion, and I think I agree it's challenging with administrative data. It may be, you know, more possible within specific cohorts of individuals, patients with particular diseases, you know, such as was mentioned, cancer. One thing that Jag mentioned that I think was actually a good point was that maybe one way, and of course, you know, understanding that we're working with administrative data here, it could be a proxy anyway for appropriateness, is looking at whether the repeat was ordered by the same physician or by a different physician. You know, which might get at the question of whether it was just because the information wasn't readily available to them.
Great, very interesting. Thank you. That's excellent. One last question for you, and it's were there any cases where the time to repeat was less than 24 hours?
You know, I don't. You know, at the individual level data, I can't answer that just right off the bat. There was one modality that tended to have a fairly short time to repeat, and that was nuclear medicine. And you know, had we had time, we would probably have gone and looked into that a little bit more, because there's certainly, you know, with administrative data, you want to just make sure that you understand the way that certain things are being billed, you know, in the system, and so we would have delved into that. But yeah, perhaps we'll go back and take a peek at that now to see if any of them were less, or how many of them were less than 24 hours.
Great. Thanks, Marion. And we got one more maybe which I'll throw at you, and that is, did you differentiate ordering that from the emergency department?
No, we didn't. And we could. In fact, I've done some work before on CT in the emergency department. So we have an algorithm to do that, but this would have included emergency department diagnostic testing or diagnostic imaging. That's not, we didn't distinguish that.
Great. Okay. Thank you. So, like many of the other areas we've looked at, asking the question always creates 10 more questions. So we're always interested to see that. So thank you very much. Really appreciate that, and would appreciate you staying on the line so we can engage you in the discussion as we move forward. So the last thing we'll do before I turn it over to Fraser and move into the discussion is just recap the findings from all 6 of the submissions. So again, the MRI, CT, and ultrasound rates, and then the rates for the different modalities, just so that you're fresh in all of your mind for the discussion. And I will turn it back to Fraser.
Great. Thank you, Simon. So we don't want the questions to stop. We're very excited to have Kathleen Morris here with us to facilitate our discussion today. Kathleen is the VP of Research and Analytics at the Canadian Institute for Health Information. She provides leadership for indicator development, web-based performance reporting, and analytics reports. She has also had the responsibility for classifications and data quality that underpin CIHI's work. So welcome, Kathleen. We're very excited to have you here, and I think you've been hearing some of the findings and some of the questions that have emerged, so we're anxious to hear your thoughts on it and also challenge all of our people out there to continue this discussion and enrich it.
Well, thank you for that very kind introduction, Fraser, and thanks as well to the 2 teams who really gave us, I think, some incredibly interesting food for thought. Certainly, as Fraser mentioned, keeping up the questions coming in is really the way to get the best out of this, so we hope that you keep sending everything in. What I should have mentioned to Fraser in the bio is that really what I actually love is data. So this data impact challenge is very close to my heart, and this idea that you can actually sort of recycle or maybe upcycle data to use things that you already have to solve problems in new ways, I think is really exciting. So we're so glad to see progress here. While you can submit your own question, we actually have one coming up for everyone that kind of get people warmed up and get into the audience participation section of the webinar. So it's a question around thinking about what have we learned. So, do these submissions or these results that you've seen from the 2 presenters, does that increase your understanding of the rate of repeated DI tests? So the choices are yes, no, and I don't know, and the poll is open. So everyone can participate in this one, and you just need to look on the right-hand side of your screen to answer the poll, and we'll leave it open for a few moments. And I think really, it's just, I found that listening to those 2 presentations, we really got some information on, sort of the size and scope of an interesting question that we probably didn't really know before. So it's, is it bigger than a bread box? Kind of information. It's really a super helpful starting point. So I think we can close the poll now. And then we always have to wait just a few minutes until the results get tallied. So I know that you're all waiting with bated breath to see what will come up. And I think what we're seeing here is overwhelmingly that it's I'm just looking with my eyesight here. 83% of you found that the answer is yes, 9% no, and 9% of you were still sitting on the fence. So maybe we'll see if the the discussion that we continue to have through the rest of this webinar will actually push you in one direction or the other. I say that I think for many of you that the challenge winners have really shown that we've got an issue that's worthy of some further attention, and we've had a chance to have a little bit of conversation about where would you go next and what might you do. I wonder if I could just ask a question of the teams around if you had to think about, if you had an extra day or two added to your deadline, what would be some of the analysis that you wish you could have done? Maybe I'll start with Eric on the pirates. Eric, are you there?
Yep. I think it would be interesting to try and dig in a bit more into the appropriateness versus just repeat as we discussed prior. And additionally, we are actually doing a bit more work in this area. London Health Sciences Center has initiated some additional analyses with this, and they're really interested in looking at that finding we found where the linked viewing system had a lower rate, and they want to try and do it a bit more systematically and really try and get down to what is maybe causing that, or if it's actually a true decrease compared to the rest of the province, or maybe it was a lower baseline rate for some other reason. So I think exploring that in a bit more detail is something we would do, and it is something we actually are doing.
Great. No, I'm glad to hear that this has prompted sort of a continued inquisitiveness on your part. How about you, Marion? If you and your team had a few more days, what might you have pursued?
Well, I think the exact same thing, actually. I mean, just this point that Jag has raised about, perhaps looking at the same position. If they're, even exploring, we have so many other data sources here. What else can we use here to get at that question? When we were in the middle of this, it's, you're just trying to answer the question, and we just really didn't have the opportunity to think that much about that question, and I think that's really the most important question, right? How much of this is appropriate, how much is not?
Yeah, it's so interesting, and it's clearly both of you are, thinking along the same lines. In my head, I could always think of how you could link that to some of the, potentially link it to some of the emergency department or hospital data where you might be able to get a little bit more on the diagnostic side of things. And I wonder, I know we have people here from the DI jurisdictional implementation group, who have other sources of data. Maybe if I could toss the question over to anyone from that group and see if there's, sort of other sources of data that you could imagine drawing on to really kind of flesh out this question.
Hi, Kathleen. It's Jeff Green here with the DI Implementers Group. We've heard your question, and there are some thoughtful looks around the room here. Is there anyone who has a response ready? Other sources? Greg?
Yep. It's Greg Riffman from the province of Quebec. I think the sources of data you want to look at to talk about appropriateness would be the reason for the exam and the result. The result, unfortunately, is not well coded, so you'd have to find a way to code that structurally. But you really do need to look at the reason for the exam and the result before you determine appropriateness. I think it's probably wrong to equate repeated with inappropriate. And as you say, this data could be needed for policymakers, so it's important to make that distinction. There's a lot of exams that are repeated for clinical reasons, for valid reasons, that may represent a large portion of the statistics represented. So reason for the exam and the result afterward, and that'll give you a lot better data source to determine appropriateness.
And are there other sources available to us beyond the DIR where we could get that kind of contextual data?
Well, and you would need skilled radiology residents and fellows.
Jeff, if we could have the person speaking right now maybe speak a little louder, that would be great.
Sure.
You need to pull in some radiology residents or fellows who would actually have to sit down there and on the system and review the order, this clinical history, and the results to see whether it was appropriate. And it would take a long time, and you probably only get a very few amount of The next thing to do, though, is to ask radiologists across the province to flag somehow reports that they think are inappropriate repeats in their report and extract that. You're never going to get a radiologist to do that.
So it sounds like some interesting ideas, but really there aren't any obvious sources springing out as to answer your question, Kathleen, other sources that are available currently.
So it's interesting, you know, I think we heard a couple of interesting responses from your group. One of the questions that's come in, or comments that's come in over the system, is whether radiology information systems might be, you know, at the hospital or hospital network level, might be a source of data that could help sort of fine-tune, I guess, some of the results that we're seeing. Anyone have any thoughts on that?
Kathleen, it's Jeff. We're definitely seeing a lot of nodding around the room, and Lena from Alberta is coming up to the mic to have a response.
Yeah. Hi. What we've done is we've taken the extract from the RIS data in Alberta for the Alberta Health Services data, and we've also taken the information from the hospital information system for admission data. One of the emergency physicians wanted us to start a shared data model, and what we did is if the emergency physician will actually put an admission diagnosis in, we can actually correlate that. So we've done that. Result is really difficult, as Greg mentioned, it's textual data, and we don't have any keywords within the result, so we couldn't do it. But one of the other things is I like the way that Ontario has done it with the OHIP codes. However, in Alberta, the code itself is not distinct in the protocols. So if the radiologist and the site can standardize the protocol for CT, because CT of a certain body part could mean something different in one site to the other. And, you know, so a CT could be done at one, you know, admitting facility, and the patient is transferred, and at another facility, the protocol is not enough. So they actually repeat the exam, and it's relevant to repeat. So for clinically, a lot of the repeats has to have that relevant data, and I think just counting the number of repeats doesn't really give information. So that's my comment.
So I guess we've heard, you know, there's a lot of interest in this information. The challenge that we have is, while we know the duplicates, we don't know the number of inappropriate duplicates. And there's been some, I think, some interesting suggestions about how we could push the envelope a little bit further. Some of them might be tighter focus around certain diagnostic groups or excluding certain kinds of care. You know, there's an idea around doing clinical or chart reviews, and you know, a note that that's an expensive and labor-intensive piece. Some potential in some of the other data sources that could be pulled in, including the radiology information system. So I think it's given us lots to think about in terms of moving the question forward. Another question that came up was around, you know, around the generalizability of some of the results that are coming across different, you know, from some of the different teams. And I think, you know, from the two that we saw today and from some of the information on those graphs that Simon presented, we, you know, saw fewer repeats in MRI, we saw more in CT, and from the one study, X-ray and ultrasound, we saw more again. Do you have any sense about whether that's a generalizable finding? Maybe I'll throw that one back to the researchers, so could start with the Avengers.
You know, I think it's pretty generalizable. You know, as we were doing this, I think we recognized that like we had to make a lot of decisions about how to handle the data. One thing we did was we contacted our colleagues at ISIS Western to sort of compare notes, and you know, in general, I think we took, you know, a reasonable approach. You can get different, you know, results based on your methodology. But we also looked at the literature. We looked at what was provided when the question was posed to look at the consistency with other findings. But certainly in the, as far as, Canada goes, I think it's probably reasonably generalizable.
Pirates? Pirates, anything else to add to that?
Yeah, I would just echo what Marion said. I think since we were including essentially all tests in Ontario in 2013, I think it would definitely be generalizable to Ontario. And then practice patterns may differ by provinces, but I think it's probably a reasonable assumption to think that the Canada-wide number is going to be somewhere in the same ballpark, I would expect.
And this is Simon from Infoway, and I think one of the discussions we've had in some of the previous webinars was around standardization of these kinds of metrics and also longitudinal trending. And so curious about the thoughts on the value of those in terms of driving long-term greater understanding and improvements.
Was that question for us?
If either of you have comments on them, then by all means.
So we did actually look at trends over time. I mean, I think it would be valuable for us, though we didn't actually find much of a change over time. Jake, do you want to add to that?
Yeah, the trend would be very much interesting to see if we are looking pre and post some policy changes or with respect to changes in the ministry's way to handle the healthcare and the amount of spending being increased or decreased. So probably the trend in itself is very, there are subtle changes, but those subtle changes cannot be observed when we look at certain parts where there are hardly any policy changes, right? So yes, it would be useful, but in certain context and not in certain areas, certain region of time.
That's great. Thanks very much, Jake. I think it's time for us to go to another poll, get everyone involved again. I think our challenge winners have really come up with some very intriguing answers, and we can see from the questions coming in and from the comments that you're very engaged in this information as well. The webinar is a great way to share some of the work, but we're wondering what other things do you think would be the most useful ways in terms of sharing this evidence that's been generated? So we'll just put the poll up, and again, you can go on the right-hand side and answer. So it's really, how would people like to get this data? Would you actually like direct access to the source submissions? Do you think gray literature, such as a blog or white paper, might be interesting? How about a conference presentation? And final choice that we have there is a peer-reviewed publication.
And Kathleen, I might just add a comment that we actually did recently have a question about how the source submissions can be cited. So we worked with our library sciences team here and came up with a citation recommendation for that. So we're moving down the path of helping people to effectively cite the submissions themselves.
Yeah, that's great, because I think there's some real richness in the submissions that have come in, and we appreciate that they're subject to some constraints that many people don't face in terms of the strict deadlines on generating the new information. So we'll just give people a couple more seconds to complete the poll. Okay, let's close the poll, please. And again, we'll just wait a few seconds for the answers to come out, and so you can see how many like-minded people are on the call with you. It's always an interesting question, really, thinking about the best way to share some of this information. And there may be no single right answer to it. So we're still just waiting a few moments, and here we go. So we're saying, actually, just over half of you are very interested in seeing, the source submissions directly. and about the same number, I think looking at the gray literature would be a good way to share it. The numbers jump up a little bit around conference presentations. So about 2/3 of you are interested in that, and 60% say peer-reviewed publications. So we're seeing quite a lot of interest, I guess, in all of the different ways of sharing it, and I think that's often the case with new information, that there's no single right option. So thank you very much for sharing your thoughts on that. Still a chance to send in any questions for the panel.
So we do have one question here, which I'll put to you, Kathleen, to manage, and that is, does the panel think that differences between the provinces in the number of imaging equipment per population would impact the repeat rates?
So I'm just going to ask you to run that one by us again.
It's a tough one, yeah. Does the panel think that the differences between the provinces in the number of imaging equipment, so the number of machines per population, would impact some of those repeat rates?
Mm-hmm. It's an interesting question, and it may be connected in some ways almost to the wait times question as well. So why don't we've already asked Eric that one. Why don't we see if Marion has some thoughts, and maybe we'll throw it over after that if, Jeff, if you're ready, to the jurisdictional implementation group. So Marion, you go first.
Sorry, I think Jag actually had a good response to that. Go ahead, Jag.
Hi. I was thinking that's a pretty good question to think from perspective of each of the tests. And as Marion suggested right in the beginning, that the accessibility of X-rays are already, we have enough and it's very simple to go about. But accessibility of complicated tests like nuclear medicine or such tests might change the results. So I'm thinking that it depends on what test we are looking at.
Okay. So what I hear you saying is just really the correlation between access, whether it's number of machines or wait times or other forms of access, actually really needs to be looked at modality by modality.
Yeah, somewhere, yeah.
Yeah. And any different comments or different senses from the jurisdictional implementers group?
Yeah, hi, Kathleen. So as soon as you asked the question there, I think everyone in the room started emphatically nodding and saying yes, that access to the resources themselves has a pretty significant impact. I don't know if anyone has a specific comment beyond that, but it was certainly the consensus in the room here was that the answer is yes.
And Jeff, I'm just going to do a follow-up on that. What about the idea of looking at things modality by modality? Is that an important concept as well? In terms of number of, say, MRI machines being a different question than number of CT machines?
I would suggest it's more the level of access and the wait time.
Sean, do you want to maybe just speak into this?
Okay.
Thank you.
Hi, Kathleen. It's Sean Thomas from St. John's, Newfoundland.
Hi, Sean.
I would suggest some of your data is influenced by, if you want to either relate it to either wait time and access by virtue of the number of machines, or however you want to put it, because they're both connected. So if your access is there, obviously your wait time is lower. Those modalities that are easy accessible, particularly when you're using within a 90-day time frame. So you're going to see the opportunity to have a repeat done within 90 days, more frequent among the modalities that have easy access. The other thing I'd like to, I think your data is directionally correct. The Canadian Agency for Drug and Technology in Health recently, in the last couple of years, released some data about the appropriateness of imaging exams in Canada. And they estimate about between 10 and 20% of those exams that are performed are inappropriate. So if you look at your data, I mean, you're within that window. But I would, if we're looking at what impact has tax had on the reduction of repeat exams, I think it's extremely valuable for us to understand the context in which those exams were ordered, and as was mentioned earlier. And if you look at oncology, for instance, patients who are having staging done for chemotherapy, fracture clinics who are doing, you know, following those types of things. Those are all repeats that are done in high volumes, and also they're appropriate. So while I think it's great work and it's interesting to look at, and I think directionally is correct, I would be really interested in seeing the percentage of repeats that are inappropriate and done within 90 days.
Okay.
Thank you.
I think you've set out a good challenge for even refining the information that we've received so far. Thank you very much, Sean.
Well, Kathleen, thank you very much for facilitating this. I think we had a very rich and full discussion. We've left people with some things to think about, and for some analysts to think about how they might be able to take this further as well. So in our closing minutes, we're going to have audience participation yet one more time, and that is around poll number 3. If there was another challenge, how would you like to participate? As that challenge is up, I'd like to remind everyone around next steps. We encourage you to share the findings of your research so far. As Simon says, we've worked out a way to cite it from the challenge specifically, but also we saw with the poll results that people wanted to, you know, attend conferences, things like that. We encourage you to tweet this out because I think the more people that can sort of know about this information, the more reaction we get and the more refinement that we can have as we go forward. If we can close, hopefully everyone's been able to answer their question, and we'll close the poll. Just a reminder that our next webinar is on December 9th as part of our webinar series. This one will deal with the questions around rate of screening of blood tests and the rate of annual physical exams for adults. So I encourage you all to participate in that one as well. Let's see, has the poll ended yet? Here we go. So we have about 58% of the people are saying they'd be a user of the data, and I'm happy to hear that a quarter people would like to participate on a team. Very few people would like to act as a judge or not participate at all. Don't worry, we'll convert you. And so without further ado, and as part of Digital Health Week, I'm pleased to announce that we are launching a second data challenge. This Data Impact 2 challenge will launch today at 3 o'clock. This one's going to be slightly different this time, folks, in that it's a 3-stage challenge. The first stage, which I think maybe some of the discussion today has already given people some fodder, is that we're publicly asking for questions. Infoway will again be working with its supporting organizations to figure out some questions, but we're encouraging you, the participants of this webinar, the general public, to also ask questions, and that's going to be between November 18th and the 30th, so you have a couple weeks to think of questions. Again, they need to be formulated in sort of the method that we'll put on our website. Once the question period is closed, we will ask Canadians to vote on those questions, and the top question will be put on the slate of questions that we'll be putting forward on December 15th. So again, researchers and analysts and anyone else who has access to data, we encourage you to look for those questions that are going to be available as of December 15th. You'll have till February 29th to respond to that and get your information in. Again, the prize purse for this challenge is around $85,000. And for those of you that are submitting questions and your question is number 1, you'll receive $100 from Infoway as just submitting a question. So we encourage all of the participation. I'd like to thank everyone for participating in today's webinar. Kathleen, great discussion. Both our teams, you did a great job. Thank you for the input from the JIG. It was very important. I'd like to thank the team here at Infoway for making this possible, and I wish the rest of you a great afternoon. And please, submit a question, vote on that question, and if you know people who can answer it, please encourage them to answer. Thank you.